I promise there'll be more time to take pictures. All right. Well, good morning. Welcome to today's congressional briefing titled Saving and Supporting Moms. We welcome federal agency leaders and congressional staffers and those watching live from our Instagram feed and the Policy Center's YouTube. My name is Dr. Ebony Wren, and I am the Director of Mom Congress, the organization sponsoring today's briefing. Mom Congress is a nonpartisan membership organization addressing the most pressing issues facing U.S. mothers. These pressing topics, which will be discussed today, include the 2024 Maternal Mental Health State Report Cards, the newest set of standards including performance metrics for health plans for some of the largest employers in the U.S., along with data and recommendations aligned to improving maternal health equity. The briefing is the start of our Hill Day, where nearly 50 mothers have traveled from around the U.S. to share their stories and advocate for bipartisan bills and what we call the Mom's Agenda. We believe and we know both Republicans and Democrats also believe that mothers and their families deserve support aligned with effective systems and structures in place to help their families to thrive. Equitable policies and intergenerational support are the key to help families in America thrive. I want to give a special thank you to our sponsors today. We appreciate your support and commitment to advance the Mom Congress mission and vision. Lansano, a breastfeeding and maternal health company with a mission to stand with the mothers. The Fund 2 Foundation, Organon, and Care International. Thank you again for your support and sponsorship. Lastly, thank you to the Maternity Care Caucus for partnering with us to host today's event. Joining us today, we have Representative Robin Kelly and Representative Young Kim, who will offer opening remarks. I'm going to read their bios for you all, even though that goes without explaining before they come up. Congresswoman Robin Kelly represents Illinois' Congressional District and is a member of the House Energy and Commerce Committee. She is deeply committed to improving the health and wellness of vulnerable communities across the country. The Congresswoman serves as leadership of several caucuses, including the Caucus on Black Women and Girls and the Bipartisan Maternity Care Caucus. Representative Young Kim. Congresswoman Young Kim is proud to represent California's 40th District, which includes parts of Orange, San Bernardino, did I say it correctly? Thank you, and Riverside counties in the U.S. House of Representatives. An immigrant, small business owner, community leader, former California Assemblywoman, mother and grandmother. Young is proud to be one of the first Korean American women ever to serve in Congress and is fighting to help all Americans have the chance to achieve their dream, just like she did. Young also serves as co-chair of the Women in STEM Caucus, the Financial Literacy and Wealth Creation Caucus, and the Maternity Care Caucus. Thank you. I will have Representative Robin Kelly come to the stage, followed by Representative Young Kim.
Good morning, everyone. Good morning. I love moms. I'm a mom myself. I'm a mom, a stepmom, and a grandma of 3. So I hope you all had a very happy Mother's Day. And to those in the room who might not be a mom, I always say Happy Mother's Day to all those who stand in the gap, because there's a lot of those people also. So I'm so grateful to the Moms Congress for organizing today's briefing. It's wonderful to be here joined by my bipartisan Maternity Care Caucus co-chair, Congresswoman Young Kim. As you might know, ending maternal mortality has been a passion of mine for almost my entire time in Congress, which I just reached my 11th year. My district is urban, suburban, and rural. There are parts of my district where only one OBGYN serves a population of over 30,000 people. Hospitals are closing their labor and delivery units without notice. And there's a lack of broadband access, which means that some expectant moms can't even have a basic telehealth appointment. I have 2,000 farms in my district, but I also have the south side of Chicago. I have parts of my district where people still are using outhouses for bathrooms. So it's very, very diverse. rural moms at the forefront of the crisis, which is why Kim and I introduced the bipartisan Rural Obstetrics Readiness Act to support rural health care facilities providing critical obstetric care. No mother should be without quality maternal health care during pregnancy, labor, or postpartum, regardless of where they live. I am proud to introduce this bipartisan legislation because it will offer targeted support for rural health care facilities in Illinois and across the country facing this crisis. It will also equip them with the necessary resources, including training and improved collaborative networks to ensure that every mom and every baby has the tools they need to thrive. Congress must work together on both sides of the aisle to protect our moms and babies. And the legislation I've been able to pass around this issue has all been bipartisan, I'm proud to say. That's why I'm also urging my colleagues to support my Care for Moms Act, which takes a holistic approach to ending the maternal mortality crisis. Because we know that we can't have a one-size-fits-all solution. The Care for Moms Act will establish grants for rural obstetric mobile units, empower doulas to support mothers, and give HHS the power to ensure that maternal health resources are equitably distributed to the communities that need them most. Congress can't do this alone, though. We need close collaboration between local, state, and federal governments. We need to collaborate with communities, with hospitals, with birthing collectives, and with organizations like the Moms Congress. When we work together, we can ensure that no mother that faces the challenges of pregnancy and childbirth without the care, support, and resources they deserve. So thank you so much. Thank you for your advocacy. We listen to you. So it's important that your voices are here. And with that, thank you.
Thank you. Robin has already shown me the way, so one, don't trip, and two, she's given a lot of appreciation to every one of you that has joined us on the Capitol Hill to advocate on issues that we as women care deeply about. So I'm really glad to be here, and I'm going to start by welcoming all of you here. Your advocacy means a lot to the members of Congress who care about these issues and actually working to find some solutions, but as Robin mentioned, we can't do it alone. That's why when you come and visit with us and knock on doors and advocate on bills that's already making it through its legislative process, and or give us information about the challenges that moms face as you go through the pregnancy. So I just wanted to, again, welcome you here. It's been a real pleasure to work with my co-chair of this caucus, Maternal Care Caucus. Ms. Robin Kelly has been a champion on this issue. She's been in Congress before my time, but since I've got myself to Congress, and when she asked me to co-chair, I jumped at the chance. I also am a mom of 4 children. 3 of them are daughters, and my daughter-in-law also. Just so happens they were all having difficulty, being pregnant. My son and daughter-in-law currently are staying in South Korea. It's their 5th day when they found out that even through their insurance, they can't, the IVF procedure that they're currently undertaking is not even covered to the full amount that they can afford. And found that, even though my son was born here, found out that it's cheaper, more cost-effective to do it in Korea. So they are over there going through their first procedure, and so I've been told that they took out a lot of 12 vials of blood and everything, the procedure that's needed. So I understand these challenges that you go through. The working on the maternal mental health issues and maternity care issues, these are very personal to me. We know that the government spends about $4.3 trillion on healthcare annually. Despite that, the U.S. has the highest of the maternal mortality rate in the developed world. Sadly, many of these conditions that we know leading to maternal death are preventable. Oh, sorry, I touched something. Okay, I'm not Ebony, but Ebony, you're gonna be with me the whole time. So I learned that limited access to educational and early screening resources or challenges in the nursing and doula workforce, as well as physical, linguistic, which I understand very well, cultural barriers to care. All of these different factors could lead to poor health outcomes. As May is the Maternal Health Awareness Month, how fitting it is for us to gather here to talk about these issues. Last month was the 2nd year anniversary of the Maternal Mental Health Hotline that was created through the Into the Light maternal mental health legislation that I helped to introduce. And I've been focused on increasing oversight to make improvements to the hotline's accessibility, effectiveness, because moms and moms-to-be need our help at every stage, before, during, and after pregnancy. So our collective work and commitment to improving maternal health care, we've been able to make some progress, but I guess there is a lot more that we can do. So the final effort obviously is to reduce the preventable maternal mortality and risk factors. So this is a term that we're gonna say all the time. Robin said it, I'm gonna say it. Congress cannot do it alone. We need partners, and that's you in the room. Nurse practitioners, physicians, advocates, talking about this on a daily basis. So we can advance care for moms-to-be, and their babies. I'm a grandma of 2 wonderful grandkids now, but I would not have had the opportunity to do that if my children didn't give up. I mean, if they gave up, I wouldn't be a grandma, I should say. But we went through the challenges of many, many years of praying and hoping to be pregnant naturally. I did 4 babies naturally. So when my daughters came to me and they were telling me about the challenges of not having the opportunity to be a natural birth, mom, it was really heartbreaking stories. So we're going through this together. So let's continue to work together, and thanks to all of you for being here again. Let's continue to advocate on issues. Thank you, and thank you, Ebony.
Thank you both. We appreciate you all coming today. Next, I have the pleasure of introducing our briefing moderator for today. And I'll also ask if the speakers can make their way to the front right now. That would be awesome as well. Jasper Hendricks, originally from Farmville, Virginia, is a seasoned public servant with a track record of fostering collaboration among diverse stakeholders. Throughout his career, he has served in various capacities, from advising elected officials at all levels of government to leading initiatives aimed at empowering communities nationwide. Jasper's expertise lies in building coalitions and forging productive relationships between government entities, advocacy groups, and corporations. Currently, based in Nashville, Tennessee, Jasper serves as the president and CEO of Social Strategies, a public affairs firm, and directs the Black Legislative Leaders Network, along with being the chair of the Metro Nashville Fair Board of Commissioners, and serves as the executive legislative assistant to the Tennessee House Minority Leader.
So thank you all. Thank you all for attending this morning. And I would like to personally thank Representatives Kelly and Kim for their commitment to Mom Congress as they have participated over the last few years in our briefings and hosted us here for our briefings. Is everybody, y'all can hear me? The mic is okay?
We can hear you, but the mic is not. But we can hear you.
Okay. So I want to begin with just acknowledging our board members, other board members that are here representing Mom Congress. I know I saw Carol. Yeah, oh, they're right in front of me. And Joy, Joy. So thank you all for your work. And Sabrina, I saw Sabrina. Oh, she's probably out in the hallway. So, and anyone else that I missed that I can't see, thank you all for your commitment to Mom Congress and improving the lives of mothers. A lot of people ask, I've been involved with Mom Congress, I think since 2019 now. And a lot of people ask, like, why would you be involved in an organization called Mom Congress? And I said, I have a mother. And I have two sisters, actually, too, who have given birth to children. But my mom is actually a special woman because she reminds me all the time that I was difficult then and I'm difficult now. And so with that, you know, I believe that my mom and my sisters should have the proper health care, as well as other women and should have proper health care, which is why I've committed to doing this work and using my resources to reach out to elected officials across the country, so that way that we can continue to improve the lives of mothers and babies across the world. So thank you again for having me here, Ebony and Joy. And I would like to introduce our esteemed panel. We have Ms. Caitlin Murphy. She's a research scientist with the Health and Policy and Management Department at the George Washington University Milken Institute of Public Health. Next, we have Nicholas Schimmel, who is the Director of Federal Affairs and Policy for Organon. And Elizabeth Mitchell. She's the President and CEO. As President and CEO, Elizabeth Mitchell supports the implementation of PBGH's mission of high quality, affordable, and equitable health care. Elizabeth leads PBGH's in mobilizing healthcare purchasers, evaluating the role and impact of primary care, and creating functional healthcare markets to support high quality, affordable care. So thank you to our esteemed panel, and I'm going to go ahead and kick it off with Caitlin. Thank you.
Good morning, everyone. Good morning. My name is Caitlin Murphy, and I am a research scientist at the George Washington University, as well as a research consultant with the Policy Center for Maternal Mental Health, and we have their executive director here, Joy Burkhardt. I am also a mother, and I am a mother with lived experience. I experienced severe postpartum PTSD and anxiety following a traumatic birth, so this is also very personal to me. And I'm deeply delighted to be here today among so many colleagues who are just as passionate about maternal health. For the next few minutes, I'm going to be answering 3 questions. First, what are the maternal mental health state report cards? What changed in the report cards from 2023 to 2024? And what actions can policy stakeholders take to improve their state grids? As many folks know here, the scope of maternal mental health in the US right now is massive. Maternal mental health disorders impact 1 in 5 mothers in the US, and maternal mental health conditions are the leading cause of maternal mortality. We know that nearly a quarter of maternal deaths are the result of suicide or overdose. We also know that screening is not occurring. Over 50% of maternal mental health disorders are undiagnosed, and we know that treatment is unfortunately not occurring. Only 15 to 25% of mothers who need treatment are estimated to receive it. And we know that these gaps are even deeper for mothers of color due to the deep systematic inequities within our health system today. Critically, we know that filling these gaps is not only a matter of life and death, but foundational for children to thrive. And despite all these massive gaps that have been well documented, before last year, there was no state scoring of efforts to address maternal mental health. And we feel that a scoring structure can provide credit to states not only for the hard work that they're doing, but also point to the areas where states need to improve. So launched last year for the first time, the maternal mental health report cards use 18 key measures to provide a snapshot of state efforts to fill these massive gaps in maternal mental health. These measures span 3 dimensions. First, we have 7 measures of maternal mental health providers and programs. For example, do states have enough therapists and psychiatrists with specialties in maternal mental health? Next, the report cards have 6 measures of maternal mental health screening. For example, do states track their screening, and what is the frequency of this screening? And third, there are 5 measures of maternal mental health coverage and treatment. For example, do states cover services for those who need it the most? And do states ensure that those services are high quality? These measures were chosen from an extensive review of all available state and county level data sets relevant to maternal mental health. However, we know that much more data still needs to be collected regarding maternal mental health, especially broken down by race and ethnicity. I'm going to take the next few minutes to briefly walk through our 2024 grades launched as this morning and how these grades changed from 2023 to 2024. So launched today, this is our 2024 maternal mental health report card map. And all states were given a letter grade based on their performance on 18 measures. The 2024 grades ranged from a B+ to an F, with the lighter color states being the higher grades and the dark purple gray being the lower grades. This year, we have 3 states with B grades, California, Washington State, and Pennsylvania, 19 states with C grades, and 29 states with Ds and Fs. And the aggregate US grade comes out to a D+. It's important to note that the state grades have been inching upward this year, which are pointing attention towards the attention that states have been giving towards this issue. So from 2023 to 2024, whoops, I'm so sorry. There are 3 important changes that we wanted to highlight. First, the US grade did improve from a D to a D+. Second, the state grades inched upwards with 34 increased state grades. So this year we had 3 states with Bs as opposed to just 1 state last year. This year we also saw 5 states with Fs as opposed to 15 states with Fs last year. And third, very importantly, we have to note that we still have a very long way to go. As said, there are 29 states still with Ds or failing grades. We're also excited to announce this year that we've added 3 new measures to the report cards. We did add a measure to give credit to a state if their perinatal quality collaborative or PQC does prioritize maternal mental health. And then also for the first time this year, we had access to state-level maternal mental health screening rates during the prenatal and postpartum period. And states were given points if they were a top performer on ensuring that that screening is happening. I'm now going to briefly walk through each one of those measures to show the improvements between 2023 and 2024. Our first 2 measures look at states' provider-patient ratios in maternal mental health. And since access to specialized care is one of the largest barriers to maternal mental health care, we consider these measures absolutely critical. So with regards to the prescriber-patient ratio, so prescribers we're defining as, for example, psychiatrists with a maternal mental health specialty, we do see good progress. We see 29 states in DC meeting that ratio as opposed to 11 last year. But with regards to non-prescribers, so for example, these are therapists with maternal mental health training, we're seeing much fewer states meeting this ratio. Right now, only 1 state meeting this ratio. And so we see this as a very important needed growth area for states. Next, we know that for some mothers, a weekly or bi-weekly meeting with a therapist or a psychiatrist simply isn't enough, and more intensive treatment is needed. As such, the state report cards give points for inpatient and outpatient maternal mental health programs. We see that 3 states had inpatient programs in 2023 and 2024, and we see a slight increase in outpatient programs in 2024, with Ohio, Virginia adding their first outpatient programs, and Florida adding 1 additional program. We also wanted to understand if states have taken efforts to create a strategic plan related to maternal mental health, as well as provide community resources to address maternal mental health. In 2024, a maternal mental health task force was added in New York, creating a total of 12 states and DC that have a task force or commission with a strategic plan. And we also see a slight increase in the number of states that have community-based organizations offering direct maternal mental health services. As I mentioned, this year, we added a measure regarding the number of states whose PQC prioritizes maternal mental health. And we were very encouraged to see that 13 states right now do prioritize maternal mental health in their PQC state level work. Next, I'll be sharing a few measures regarding state progress toward maternal mental health screening, which we all know is absolutely essential, and knowing that we're still a very long way from universal screening. We're excited this year to introduce 2 new screening measures pulled from state-level HEDIS data sets that were available for the first time this year. We do know that state-level maternal mental health screening rates are very low, with an average of a 4% screening rate reported by commercial plans and 7 to 8% screening rate among Medicaid plans. Yet, we want to give credit to the states who we consider top performers, who are screening at least 10% of their mothers. We found that 7 states screened 10% of prenatal patients, and 8 states screened at least 10% of their postpartum patients. So clearly still a long way to go, but we're giving credit where credit is due. Next, knowing that insurers are an essential part of this conversation, our next 2 measures look at insurer requirements. 8 states right now require Medicaid insurers to track their screening rates, so we know there's more progress to be done there in terms of tracking these rates. And second, 2 states right now require insurers to develop a quality management program for maternal mental health services, which is one of our key policy recommendations to make sure the services being provided are high quality. And our next few measures do seek to understand how frequently providers are actually submitting claims to insurers. So is reimbursement actually happening? Perhaps unsurprisingly, private claims submitted for maternal mental health screening is very low. This is often because screening is bundled into a global obstetric package, but states are starting to carve out screening to incentivize reimbursement for screening. Right now, we only have the data for private insurers, but we are hoping to be able to provide that for Medicaid in the future. So in 2024, we saw there were states that billed at least for 1% of mothers. Again, very low rates of screening, but we saw that increase from 3 states to 8 states in 2024 during the prenatal period. And during the postpartum period, we saw at least 1% of obstetric providers billing for screening, raising from 15 states to 19 states. When we turn to treatment, we gave states points if providers submitted claims for treatment among at least 10% of mothers. And we're defining treatment as, at a minimum, counseling, as well as therapy and psychiatry claims. And considering that 20% of all mothers experience a mental health condition, we consider 10% a minimum bar. In 2024, we saw the frequency of claims submitted for prenatal treatment improving in 10 states, and we saw the frequency of claims submitted for postpartum treatment improving in 4 states. Our last 2 measures look at state efforts to make service coverage available for those who need it most. So as we know, Medicaid and Medicaid coverage postpartum is absolutely essential to make sure that health coverage is maintained throughout the entirety of the postpartum period. So in 2024, we saw states extending their Medicaid coverage to 42 states in DC, and 10 additional states extending their postpartum coverage to 1 year postpartum. So each one of the 18 measures that I just mentioned are now available in a state snapshot on the Policy Center website. The snapshot allows you to see within your own state which of the measures your state met and which of the measures your state has not yet met. We do encourage you to go on the Policy Center website at policycentermmh.org state report cards to check that out, as I mentioned, as of this morning. And we also encourage you to think about, as you look at your state grades, what will it take to help increase these grades in 2025? So for example, as we saw, states don't currently have enough therapists and psychiatrists with specialties in maternal mental health disorders. We know that states lack hospital treatment programs and community-based resources regarding maternal mental health. We also know that health plans are reporting very low rates of maternal mental health screening among both commercial insurance and Medicaid. And I apologize for the error. States do not often require health plans to create quality improvement plans. So alongside the report cards, we encourage you to check out the Federal Maternal Mental Health Policy Roadmap, which is up on the Policy Center website. And as folks may be aware, which is very exciting yesterday, was the launch of the National Maternal Mental Health Task Force Force and their policy recommendations, which the Policy Center helped coordinate. But to see our specific recommendations, we encourage you to go to the website. For example, just a teaser here, the types of recommendations we're making is that HRSA does prioritize addressing maternal mental health provider shortage areas, as well as create a national mental health provider psychiatric consultation program. So I'm going to pause there, but looking forward to discussing more during the Q&A, and thank you so much for your time and attention today. I'm going to turn it over to our next speaker, Nick.
So yes, next we will have Nick Schimmel of Oregon, who will discuss maternal health data and state populations.
Thank you, Jasper. As he just mentioned, my name is Nick Schimmel, and I lead Oregon's DC policy team. I just want to start by thanking Mom Congress and all of the advocates and other folks who are here on the incredible work they're doing to address maternal health and the myriad of aspects and issues that fall under that umbrella. I also want to thank the Maternity Care Caucus for their continued work in this space, and certainly I know there's a lot of work left to do, but I feel very hopeful that we can make some progress there. Maternal health, broadly speaking, is an incredibly bipartisan issue that's seeing increasing interest and attention from both the public and policymakers. Every corner of this country has women who face the numerous challenges and health issues that would fall under this discussion. If someone were to ask the question of what constitutes maternal health policy, you'll likely get a range of answers, and that would be understandable. That's because women's health, and maternal health specifically, can mean so many different things to so many different people. It's why it's so important for us to focus on the life cycle needs of women, from reproductive health to later stage needs. Maternal health has a role throughout this process, and it's a very reachable goal to leverage health policy for improved outcomes. At Oregon, we're focused on changing the conversation around women's health. That includes reproductive health, later stage issues and diseases, and a variety of mental health issues such as postpartum hemorrhage. Since our evolution to an independent company in 2021, our leadership has been very vocal in investing in unmet and undermet needs of women across the globe. One of the first things we identified was addressing the lack of care options in the maternal health and contraceptive space. I know oftentimes when people think of maternal health, they don't think of contraception, and they don't think about family building and family planning, but it's an integral part of that process. Nearly 40% of all pregnancies in the United States are unintended, representing significant challenges for women who want to plan for the future of their families. Of those unintended pregnancies, roughly 43% occur in women who use contraception inconsistently or incorrectly. But solutions for these issues exist. The first thing that can be done is provide women with more options. Nearly 19 women in the United States live in what we consider a contraceptive desert, which is an area without a range of contraceptive methods available to women. Those contraceptive desert areas are found in every state, every district across the country. They also become more pronounced in rural communities, where the points of care and provider options are more restricted. We also know that there's a significant public support around improving access to contraception. A December poll showed tripartisan support of 92% for access to multiple forms of contraception. Nearly 90% of respondents in that poll supported increasing access to effective forms of contraception and agreed that contraception is a reasonable means to prevent unintended pregnancies. But that's not a unique poll. A number of other recent polls have supported those numbers, indicating that consistent, broad bipartisan support. Knowing the support exists, the next question is, how do we get there? Well, there are a number of ways that we can do that. Examples include addressing provider training. We've heard from the earlier speakers that this is a consistent issue, making sure that providers know what the care options are, know what their patients' needs are, and find ways in which they can address that. Second, we can find ways to address access to multiple forms in different care settings. We know that rural and urban communities have these issues. We know that there are a number of different points of care in which women pursue those options, and finding ways in which we can address some of those gaps is a good step forward. Third, we can collect better data so that we can identify these problems. I think first and foremost, when we talk about maternal health and the range of women's health issues that we look to, we have to understand that there's a shortage of solid data for us to be able to go after these issues. And lastly, find ways to address barriers to seeing providers. how can we make it easier for women to see their healthcare providers? How can we make it easier for them to pursue care and the issues that they need? Because when women can see a provider in one visit, their likelihood of pursuing a contraceptive solution improves. The more women have access to and an ability to see their healthcare provider, the more likely they are to pursue additional care and screenings. When women have more of an ability to determine their own family building timelines, it leads to better outcomes. While the problems impacting maternal health are significant and numerous, there's also light on the horizon for when it comes to solutions. The issues of the Mom Congress are reflective of the challenges we face, but a focus on the concerns addressed by the Moms Agenda is a step forward in tackling the maternal health crisis. We know that women's health and maternal health means a lot of things, and looking at the Moms Agenda, it's clear that that covers a range of issues and options. But it also means that we have solutions. And with this being such a bipartisan issue, I think that there is a lot of opportunity for us in the future to work together, both from a public standpoint as well as a policymaking standpoint, to get to those goals. Yeah, I think there's a lot of opportunity left ahead of us. And I just want to say thank you for the opportunity to chat with you today and to present what I consider a slightly different aspect of maternal health, but an equally important one. I look forward to the progress ahead. Thank you.
Thank you, Nick. And next we'll have Elizabeth with the Purchaser Business Group on Health.
Thank you. I know that name does not roll off the tongue, but I am so pleased to be here. This could not be more important. I represent very large employers, Walmart, Boeing, Apple, Microsoft, just really, really large companies. And private employers and public purchasers pay for over 50% of the births in the US. So if we are aligned with Medicaid and state policies between us, I really think we can make a difference. So we have recently released results of a 2-year working group with our large members. This was co-chaired by Walmart and Qualcomm because they look at their data, our data coming in, and they see that maternal health is not improving. They are paying a lot and they are responsible for significant workforce populations and families. They are not getting the care they need. They're not getting the outcomes they deserve. So they took it upon themselves to actually do something about it. So our mission for over 35 years has been advancing quality, affordability, and equity in healthcare. We do that through measurement, policy advocacy, payment reform, care redesign, health equity initiatives, but also just making it absolutely clear that these very large companies who are paying $350 billion annually for care about this. And they are taking this to their health plans, to their provider partners, to their state policy partners, and saying, we expect something to happen. I am gonna say, though, that when we had all of our members assembled to start talking about these priorities that we had identified, we did invite some health plan representatives to come respond, and one just said, well, we just have never prioritized this. And it is so shocking to me that they're hearing it from patients, from communities, from policymakers, now from their big jumbo employer customers. So hopefully it will start mattering. So we launched this work group about 2 years ago. We wanted to come to consensus so that we could tell the market what we care about. It is absolutely aligned with everything that you have heard here today. We want comprehensive care. We really want to just be able to share what matters most to us in terms of measures. Good news, they are absolutely aligned with the measures that you've already heard about, and really collectively agree on the purchasing principles. So they can put these metrics and standards in their contracts and really expect movement and progress. So this is a very short, by design, on purpose, measure set of things that they will expect in all of their contracts from all of their provider partners. We want to understand the C-section rates. We absolutely want to require prenatal depression screening and follow-up. I am so appalled that 10% is like best practice. We have so much to do. So maybe this will help with some leverage, saying, come on guys. We absolutely expect maternity postpartum follow-up care and coordination. We want social needs screening. Moms are in a community. We need to make sure their housing and food needs, everything is being addressed. I'm telling you, this is a big step from what's happening now, but when we collectively say this is what matters and this is what we expect, I think we're gonna see some progress. Absolutely measuring patient experience. We really want to understand severe obstetric complications, and this all needs to be publicly reported. Not at some system level where, you know, some hospital in one state may be able to do it, but the other hospitals in the system can't. We need transparent reporting at the facility level so that patients and purchasers can know what the performance is when you are making a decision. We want to know about midwife deliveries and patients who use a doula. Every one of my members is trying to add doula coverage right now. They have said this is a no-brainer. I will tell you, sometimes their health plans say, well, no, why do you want to do that? So they prevail, we're getting there, but then we have workforce barriers. We have payment barriers. In California, we were actually able to sort of change scope of practice laws to actually enable more partners to provide care. They're not getting reimbursed. So we've got to go beyond defining scope of practice to actually requiring that these partners in care delivery are actually paid. So again, none of this should be rocket science. Frankly, it should be the standard of care already, but equitable care that promotes cultural humility and respect. High quality care with evidence-based care models and care coordination with optimal, equitable clinical outcomes. Access to timely patient-centered care and resources. We have to address maternity deserts. Thank you for saying that. They are growing. Our members cannot find providers in so many communities for their employees. It's not a payment issue. The providers are not there. This is a huge problem. We do have recommendations in our new report about how you might pay differently for rural care. Got to get past fee for service. It isn't working. We've got to pay community providers. We have to really make sure we are addressing maternity care deserts holistically. Actionable, transparent, quality outcome data, absolutely stratified by race, ethnicity, language. We know there are disparities. We have to be able to see them in the data to then really take more action. And then a near-term transition to new payment models. What we're doing now just isn't working. So it's time to move. Some of the basic recommendations: more accountability through better data. It's got to be transparent. They're absolutely changing their benefit coverage for better maternal health care. We literally had one of our large members just say, all right, we're just gonna do a direct contract. We're gonna design this ourselves. We want maternal health paid for. We want social needs screening paid for. And they couldn't find a partner who would do it. So we have got to move the market on this. Absolutely educating and engaging workers in the care that what do they want, what are the barriers, and then developing the contracts that pay for this. So our members are gonna take that on. This is just a quick list. You can find it online, but we had so much input from midwives, from doulas, from employers, from clinicians. We really just needed this to be a comprehensive effort, and we're really pleased that hopefully it represents at least the first step. And some policy barriers, and there are many. We are fully supportive of all of the policies that have been discussed here today, and we will lend our weight to that. Sometimes Congress cares when these large companies say this matters, so we will be doing that. But eliminating health disparities, prioritizing care quality and patient safety, quantifiably improve clinical outcomes. We've got to increase access to prenatal, postpartum mental health care. We also need to integrate it into primary care. We're facing so many barriers to do that. Our members have said publicly they want to pay for primary care that includes integrated behavioral health. We need to support these quality measures, safety measures, and they've got to be publicly reported. And I'm sorry, I know everyone thought early elective deliveries was topped out. That was wishful thinking. We have got to go back to measuring and reporting that, promoting equity, and really addressing the workforce shortages, especially in rural areas. So I'm just here to lend my voice. I'm a mom of 4, a grandmother of 1, and we know that it is going to take all of us to do this. So we're bringing my employers and public purchasers. We want to partner with Medicaid and states and Congress and all of you, because you're doing the work that really is going to make the difference. So we are here to help, and we're just so excited about the partnership and the promise, because this is too important not to take on. So thank you.
Thank you, Elizabeth. And before we have our last presenter, no, you come up. I just want you guys to get prepared to ask your questions. I know I have a few. But next we will have with us Ms. Mia Keys, and she is the Director of Federal Government Affairs at Hologic. And she's gonna talk about something that we're gonna be facing in the future. So, you can advance to the next slide. Yeah. There you go. All right.
Thank you, Jasper. Thank you, Ebony. Thank you, everyone, for being here. This is a fantastic convening. I'm so happy to see your faces. I am a former staffer, and so sitting in rooms just like this one, day in, day out, and every time I'm back in the building, my heart just beats even more because you all are essentially, even though you don't have the title of policymakers, you make policy, and you make laws that will ultimately change the course of people's choices, their healthy choices to make for not just the current generation, but for my children, for progeny, for your grandchild, which that people don't believe you when you tell them. But as Jasper mentioned, I'm Mia Keys, and I work for Hologic. I serve as the Director of Federal Affairs, and if you've not heard of Hologic, you've certainly at least come across a number of their products. So if you've ever had a mammogram or love someone who's had a mammogram, or if you've had a pap smear or an HPV test, Hologic is in that space. We're primarily in the breast and the cervical space, but also just across the continuum of women's health. And what's interesting is that Hologic itself doesn't actually work on maternal health issues, but I come from a background of maternal health and I cannot step away from it. Prior to coming into this space, I served for a long time as the health policy advisor to Congresswoman Robin Kelly. You heard from her this morning. And I also eventually served as her chief of staff and did a stint at the AMA in between those two to help stand up their Center for Health Equity and through their policy lens, which matters in terms of my own work. And then also, I must say, I'm a public health researcher by training, and I'm currently completing my doctorate degree, my dissertation on health equity, policy, and artificial intelligence, which is what I want to talk to you about today with respect to maternal health. So first and foremost, AI is everywhere. We hear it all the time. We have ideas of what it is. Congress is now taking a major interest in it, especially after COVID, and particularly after telehealth services became commiserate in terms of reimbursement with in-person patient presentations, right? And then from there, we started to see a lot of conversations around artificial intelligence. But what exactly is it, right? So AI, just very basic definition, and I'm not assuming that you know something and you don't, but I'm just going to speak very plainly. AI refers to those technologies that mimic mimic the intelligence of humans, right? That's the basic foundation, right? But what does that essentially mean in terms of our everyday, right? So pretty much AI is everywhere, across every single sector of life. Many of you took the metro here. Your metro ride was based on an algorithm that someone designed somewhere, right? And you got here safely, hopefully. There are times where when you're eating, your food comes from sources with respect to farms, and agriculture depends highly on artificial intelligence. We see it in the financial sector in terms of Wall Street and stocks and everything in that world going up and down. You certainly see it for better or for worse in surveillance spaces, and we've been having a lot of conversations these past couple of years about the role of AI in the justice system. But with respect to healthcare, it is an extremely unique space, AI is, right? So that's AI, but AI in healthcare is unlike the way it operates anywhere else, right? So first and foremost, healthcare, as we all know, is extremely regulated, right? And we're regulated by federal agencies, primarily FDA, Food and Drug Administration, and Centers for Medicare and Medicaid Services, CMS. Now keep that in mind, because both of those agencies were founded way before anybody could imagine anything around AI, right? Which really didn't come into conversation until about the 1950s. But what does that mean in terms of the way that we come to experience medical care in the 21st century? It means that a lot of times your providers are depending on algorithms, which, by the way, an algorithm is just a pattern of steps, right? Your providers are depending on an algorithm to, when you come to the front desk, take your name, take your birth date, take your whatever identifiable information. All of that is input as data into an ethereal cloud that ultimately follows you everywhere you go, or at least it's supposed to. And it informs the way that everyone interacts with you at every single step of your medical experience. And for women or birthing people who come into spaces because they're expecting a baby or they're caring for a child, it usually shows up initially in that space in terms of patient flow, right? Not necessarily touching the body, but just identifying who you are and the spaces that you occupy in terms of the needs that you have in terms of your health, right? So that's the first space where you will see AI often operationalizing itself within the maternal health space. Another space that you will then see it in, it has to do with, well, what kind of birthing experience will you have? I have a 2.5-year-old, and I was considered a geriatric pregnancy, which baffles me all the time. I think that's, I mean, I have some grades, but it's not, you know. And this job gave it to me, so be careful. But, you know, it was fascinating to me because, you know, I'm telling them information, they're inputting things into, you know, click, 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 click. What does that mean in terms of my care? Well, that means that I then had to, for the last probably half of my birthing experience, check my blood pressure through different tools, and then I had to input that data into a mobile app, which then went directly to my provider. Many of you have had likely experiences like that. If you yourself have not birthed, you certainly come into spaces where you see that, right? Or many of you may even have mobile applications on your phone that talk about how many steps you're walking or what you're running or how many minutes you're meditating a day. All of that is a little different than what actually happens in the AI healthcare space because this is not regulated, right? Your mobile applications are not regulated. But when it comes to maternal health, we're seeing a lot of things happen. A lot of what we're seeing in terms of the AI technology proliferating are a lot of mobile applications are coming to play to help women really go through a birthing, to essentially have a tremendous birthing outcome and tremendous experience. Not so much the problem with the applications itself, but the problem with the ecosystem with respect to AI in healthcare is that the system, which was designed when Medicare and Medicaid was established in the 1960s, when the ACA dropped in 2010, and then ultimately in 2014, all of these preventative related statutes came into play. None of that, again, could imagine what we would be dealing with in 2024. So what starts to happen now is these are unregulated applications, but they're necessary, especially when you're dealing with the unique situation of the maternal health crisis in the United States. I depended very much, and this is not a marketing type of situation, but I depended very heavily in my own birthing experience on the application called Earth, right? Because when I was with Miss Kelly and she talked about her work, we wrote the first bill in congressional history with respect, like comprehensive bill with respect to maternal health. So for years, my mind has just been on, well, as a Black woman, I'm more likely to, or a Black woman, you know, so this was in my mind as I was going through my birthing experience, so I had all the tools, right? Including this one called Earth. It's IRTH. It's Birth Without the Bias. And this particular app is developed by a woman named Kimberly Sellers Ayers. I always get her last name. It's Sellers. Ellis. I know Kimberly. She's a fantastic person. Just look up her. Yes. And then there are many other apps that are similar. But because it's not, I'm offering that app as that application as an example to just demonstrate that that application is not considered a medical device under the 21st Century Cures Act, which matters in terms of reimbursement rates. If providers are not incentivized to say to their patients, hey, as you're going through this very stressful situation, consider augmenting your experience with this, you know, this particular application or whatever technology. Providers won't necessarily say that because it's not, maybe they will, but for other examples, they're not reimbursed for it, right? So the conversation has to be, well, how do we integrate artificial intelligence into a birthing experience on top of the fact that we're already living in a world that was never created, not only with AI in mind, but not with the birthing experiences of Black and brown women in particular in mind, right? So what does that mean when you start to layer that conversation? And I'm gonna come to a quick close because really my time today here is meant to generate some thought. As staffers, as people who are advocates, maybe yourselves, are mothers or grandmothers or aunties and uncles, birthing people, it will be incumbent upon you to think about the ways that we have to reimagine our healthcare system. And imagine it not even just for the downstream, really exciting, innovative ways that AI could potentially really move us past some diseases that will never, maybe in 30 years will never be with us, certain cancers will never be with us, maybe diabetes won't be with us, and AI could be a part of that. But when it comes to issues that have to do with maternal health, where so many of the issues are upstream, where so many of the issues are structural, where so many of the issues happen outside of the traditional clinical setting, AI itself, the actual application, will not necessarily be the panacea, unless they are designed with digital determinants of health in mind, right? So who sits at the table when they're talking about what goes into the algorithm, those patterns of steps? Who is a part of ensuring that the data that's collected when you come and present for care at the desk the first time, when you're going through your clinical experience, all of those data go into the algorithm to then say, okay, well, this will generate a response or an outcome. And by the way, I want to give just one example about how powerful an AI algorithm operates in the maternal health space. How many of you have ever heard of the VBAC calculator? How many of you who have birthed have ever had a cesarean? I had a cesarean. Okay, very good. How many of you have another child after that cesarean section? And was that a cesarean or a vaginal birth? Cesarean or vaginal? Okay, most of you had another cesarean. A couple of you did, which is perfectly fine. There was an algorithm that determined whether or not you would have cesarean after that first cesarean. It's based on the VBAC calculator. So it's the vaginal birth VBAC. VBS. Vaginal birth after cesarean. There we go. Yes. Letters. I'm actually a writer, people. Writing and speaking is a whole different thing. But the VBAC calculator is an algorithm that determines one's likelihood of a successful vaginal birth following a cesarean section, right? The thing about the VBAC, up until 2022, the VBAC calculator was based on an algorithm that incorporated race and ethnicity. And for Black and brown women, Black women and Latinas, consistently, the outcome based on that algorithm essentially said, this woman will likely is not the likely candidate to bring forth a baby vaginally, therefore she should have a cesarean section. We already all know, and I'm not sure because I was dropping off my child, if anybody talked about cesarean rates and how they contribute often to maternal mortality and morbidity rate, but all of that matters, right? So now there's conversation, people are paying attention. How do we ensure that there's no bias in the algorithm? Which, by the way, I don't think is the answer, but it really does have to do with ensuring that we're using and thinking about these social constructs, these upstream issues, structural issues, in a way that once it comes to the innovation, it's empowering the innovation. It's not damning the innovation and thereby exacerbating existing inequities with respect to birthing outcomes. So anyway, if you want to know more, come to my dissertation. I'll talk to you all about it. But thank you so very much for
So before we get into our question and answer, we're gonna call up a very special guest. We have many of our sponsors are here today, but we have one that would like to share with us the importance of philanthropy in this work, so that we can have an overall picture before we go into our question and answer. And so remember to keep your questions, get your questions ready. But I would like to call up Ms. Linda Wilson, who is the Executive Director of the Fund 2 Foundation.
I didn't know I was coming now. I thought I was waiting for the question. And just so you all know, I don't know about you all, but I think we need to add debriefing after every person and have little group talks. You know what I'm saying? I am reeling, and I'm like, do I need to even say any of this? But anyway, because I go down rabbit holes. This is very personal. You all know what I'm talking about? It's, you know, I'm trying to be system and philanthropic and all that stuff, but deep down it's like, yeah, 53 years ago I went through that too, you know, or whatever. Yeah, I'm a great grandmother, so it's really hard to balance the objective and the data and all that other stuff when you start. I'm not saying you're triggered, you're just reminded of all the issues that 53 years ago, the change is, not much. Going through the same kinds of things, and I get very disgusted by that, I must tell you. So, my folks wrote this, so I'll have to read it. Otherwise, they're like, why did I bother with it? But just some information that I started thinking about, and that is, when we were just at the African American Mayors Association, and we met 3 mayor doulas. I know, I was like, wow, I hugged them so much. And we actually gave them what we call Moses baskets for them to take back for their constituents and everything. But they were, just so proud of being a doula that they talked about that more than they talked about their mayoral duties. So I think it's important that we know that they're in the Bible Belt. So, it's not always accepted so much, but they're working at it. So just know they're there. I also wanted to say, I met with a group yesterday that we now have an official partnership. My staff didn't even know this yet. But Justice for Black Girls, I don't know if you all have ever heard of them, and they have agreed to amplify the message earlier to their group. So use them, you all. Hey, and another thing that I'm very proud of is that we have grief boxes for people who lose parents or even the children. Actually, we have them for a lot of people who lose children through violence, period, or whatever. But I just thought, now I am gonna do a commercial. I just saw this book, and if you haven't seen it, you didn't bring them all.
I did not.
I know, she only brought 2, and I took them, I must tell you. But this is an amazing book, so I'm gonna leave it here for somebody to look at it if you get a chance. Xaviera has it. So, all right, now I'll be good and read my stuff. Good morning, everyone. I'm sorry, I'm so silly. I love getting old, I just don't care. And hello, Mom Congress. Fund 2 Foundation is a proud new Mom Congress Advisory Council member, and we stand ready to serve. Thank you, Jasper, Dr. Ebony, and the Mom Congress team for all you do. I would also like to our friends who left, Representative Robin Kelly and Young Kim, for their leadership in the Maternity Care Caucus. I had a lot to tell them. I'm gonna chase them down. This year, I'm excited to be back with you all and want to express my gratitude to each advocate who has come from near and far. At Fund 2 Foundation, we believe we are all part of a connected community, striving to build a village that also saves and supports moms. We were founded by Robert F. Smith, and maybe you all know him as the guy that paid off the Morehouse student debt. That's when he broke the internet and drove us crazy, I must tell you. $34 million. Have you figured out how do you give $34 million? Anyway, it was hard. Anyway. What we wanted to do was to advance social change and create an enduring American legacy. Robert, I can tell you firsthand, learned early on the power of activism, philanthropy, and a mother's love. He credits his mother for doing, I think, once a month paying an amount of money to the UNCF when he wanted tennis shoes. And she said, no, this money's going to UNCF. So he kept that up, kept going with that as he grew older. 2 years ago, to this very week, we wove those principles into what started as a lunch and has now grown into our Black Maternal Health Equity Program. We work to convene, educate, and amplify our and your voices toward a future where Black maternal health thrives. As everyone says, philanthropy nor anybody can do this work alone. Just as our policymakers must reach across the aisle, we have found that we must reach across sectors to advance maternal health equity. And I'll tell you, that's been our pain point. When we first got into this, and I'm no expert, I'm just like a personal recipient of bad health care, but what we discovered was people don't work well together. We've got this model, or Eurocentric model, that we just keep, we have what's on our mind, and we go for it. And then we talk about the village for the kids. We need that village too. I'm a firm believer that we have all we need, We truly do, and that if we would stitch some of the quilt pieces together, we wouldn't have to be begging all the time. That's another story. So, and while I may not directly be involved in the day-to-day work, I understand the toll it can take. And this is they put this in here, I'll say it, okay. From my days as a Black Panther to my current role in philanthropy, I recognize and honor your tireless work on the front lines. Deep within us, if we truly listen to each other, we will find the answers. Our ancestors knew there was a better way to live, and we can infuse that wisdom into our culture through small changes. As Eloise Greenfield beautifully wrote in The Woman Who Caught the Babies, our communities have long held the solutions. You, the moms, midwives, doulas, physicians, nurses, grandmothers, partners, and advocates are sparking that change. Today, as you walk these halls and into each office to share your story, remember the power of your voice. The time for action is now. Let's find where the money is that's being wasted.
Yes. Yes.
We are on that, you all. Robert Smith is a billionaire and he does not play about the money. It's like, they got money, let's go get it. So let's find out where it is. Let's train the next generation of clinicians to provide whole person care. Let's engage all parts of our families. Let's ensure that all birthing people can access doulas and midwives. Let's support dialogue that explains policy initiatives in plain language. Quite frankly, that's why I got involved in this. I was like, okay, they doing all this work, but I don't know what it means to me when I go in the doctor's office. So can somebody just give me a little card? So when I go in there, I can say, well, the law said you have to do this, that, and the other. Let's serve vulnerable pregnant people in every state. And just so you know, we work in the Bible Belt in particular because that's where 50% of Black people are, and that's where some of the troubles are, and we're gonna consistently do that. Let's harness AI, yay, technology and innovation to improve maternal health. Let's turn data into action, and let's lift our voices and share our stories to save and support moms. Together, let's ensure that every mother and child thrives. Thank you and amen.
So, thank you all, thank you to our esteemed panel. Before I get into the questions, I'd like to recognize, because we talked about a lot of work that we are focusing on here in Congress, but during our presentations, we also heard of some work in the states. And I would like to recognize a state delegate from the Commonwealth of Virginia, Candy Munden King, who has been on the front lines there in Virginia in improving maternal care. So our first question that I have is, Caitlin, looking at the report card, why do we not see any A grades?
That is a wonderful question. I love that question. That's the question we want asked. So right now, I walked you through those 18 measures, and thank you for bearing with me as I went through all 18. The 18 measures are scored on points from 1 to 4 points. And the 4 points are for measures that directly impact maternal mental health, such as screening rates. Things such as Medicaid expansion, postpartum Medicaid extension, getting more 1 or 2 points. We know that supports maternal mental health, but those are getting less points. So what we're seeing is that states are not hitting those 4 pointers. So when we look at the total number of points a state can get, they are not putting their resources and they're not leveraging the opportunities to directly address maternal mental health and get those 4 pointers. So that is when it comes to screening, making sure that screening is actually happening, making sure that there are providers that are trained in maternal mental health in particular, community-based resources that provide those direct services. So we're not seeing A's because states are not directly investing in maternal mental health.
And so this could be open to anyone on the panel, but specifically Elizabeth, you can kick this off. Can you talk about the linkage between women's economic security and maternal health care?
Good try. One thing I'll start with is lack of affordability of healthcare is the primary barrier to access. So we also have to tackle healthcare affordability. I'm actually on the board in California of the Office of Healthcare Affordability. We just set a limit on cost growth. You would think the sky is going to fall because it just was not well received, but we had people come at every hearing, teachers, carpenters, hotel workers, just talking about the barriers and the burdens of healthcare costs, not being able to afford, their car, then losing their home, then because they've lost their job, all because of healthcare costs. So I know that wasn't your exact question, but if we do not tackle healthcare affordability, the money's coming out of wages. We've lost over 10 years of wage growth to healthcare cost increases. Prices are out of control. They have nothing to do with quality. And if we do not tackle that, we will continue to see huge barriers to access to healthcare. And we haven't even talked about childcare, which is also unaffordable. But we have to enable economic prosperity for women and families for them to be able to thrive. Okay, good.
Yeah, I mean, can I just add that, when we talk about women's health in general, right? I mean, it lasts the extent of our lives. And, I think especially when you talk about the journey to motherhood, it starts before pregnancy, obviously occurs during it, and then lasts for the rest of a woman's life. And I think when you talk about economic stability and empowerment, it's about making sure that they have the ability to choose their care providers, making sure they have access to the care that they need throughout their lives. And then obviously making sure that, they have the ability to determine how their families are going to be structured, how they want to develop a career addressing healthcare costs, et cetera. So I think there's a lot of things that we can do, and honestly, a lot of it has to get down to the bottom line, which is sort of the stigma around women's health in general. I think there's a lot of opportunities there, and I mentioned it earlier around addressing these issues. And like I said, every time I bring up this discussion with someone, to them it means something different. But I think that's also representative of the fact that we have so many challenges to overcome. And I think it starts with having the conversation. But at the end of the day, making sure that women have access to the providers they need, and of course the care they need at the end of the day.
I completely agree with both of what you have mentioned. And I also want to offer that in the United States, because economics very much intersects with race in a unique way, irrespective of a woman's economic outcome, we still consistently see terrible rates with respect to morbidity and mortality for Black women, for brown women, right? Let me back up. For your own edification, because I'm a whole nerd, I'm going to implore you to please read a seminal study by a scholar named Bruce Link and Joe Phelan, Phelan. It refers to the fundamental causes of health. And it's an entire treatise on the way that economics operates on the body, and it also goes into social related issues as they uniquely play out in the United States, namely race. But we see consistently in the stories of Serena Williams, Beyonce, Kara Johnson, whose name was the first, I'm not sure if Ms. Kelly spoke about Kara Johnson, but her name was the first to be introduced into the record with respect to maternal health, because she was a polyglot. She raced cars, she jumped out of planes. She and her husband, Charles Johnson, who's the son of Judge Glenda Hatchett, they by no means were without what they needed. They had everything they needed, and Kira still died on her birthing 14 hours after giving birth to her child. It had nothing to do with her ability to access care. She had the best care afforded to her. On top of this conversation that we have to keep in mind, in addition to what my co-panelists have mentioned, is the way that race operates on top of gender, right? So having the intersectional conversation in the United States, how it operates on top of healthcare experiences, and how it also operates with respect to socioeconomic status. And then finally, I'll offer, because it's not easy to have these conversations, right? And this is not a conversation to make anyone feel badly. It has everything to do to the way that you're going to be galvanized to bring these conversations into your home, amongst your friends, in your communities, if you're not already having them, and to just challenge yourself to really understand what we're talking about is socially structured, which means we can reverse it. But we can't just have the conversation about economics and say that that's that. Finally, I'm so sorry. I had pregnancy brain is real, and I had a baby 2 years ago, but it is real. But so the other thing to also keep in mind, and this just makes it even more vivid, and there's another study that came out of Harvard by a guy named Chiro Kawache and David Williams. You can go and read it. I'm not just spitting facts off the top of my head, spitting things off the top of my head. These are scientific. There's an entire course of studies that studies the birth weights of Black women who were born in the United States compared to white women whose babies were born in the United States, compared to African American babies born to African mothers in the United States. First and foremost, the birth weights of the Black babies born to Black American women were consistently lower than the weights of the white babies born to white women. And even if the Black woman had a master's degree or higher. In fact, the more education she had, the lower her birth weight in comparison to the white woman, even if the white woman had just a GED or high school education. Okay, and education is tied, of course, to socioeconomic status, so on and so forth. And then the thing on top of that, related to the Black woman and the African-born Black woman, the weights of the babies born to the African woman, for the longer she was in the United States, started to look like the birth weight of the Black woman, when initially when she came to the United States, her birth weights of her babies were more akin to white women. So it's not biological. It is structural, it's social, it's the stress associated with discrimination. We have to have that conversation.
Thank you. And so, Nick, you spoke earlier about deserts, and for instance, in Tennessee this year, my boss, we were able to get through a 12-month refill in birth control prescriptions for 10 care patients, people who are receiving our state health care. And that's because a lot of them live in rural areas. But as far as like we're here in Congress, what can Congress do to help mothers in some of these care deserts that you're seeing?
Yeah, no, I mean, I think that's a great question, and the statistic was referenced earlier, but I think one of the best things that Congress has done in recent years is include, the 1-year postpartum Medicaid extension, right?
That was Ms. Kelly's bill, by the way.
I'm aware of that, yes. And I would just like to say that, I think that is an incredible step forward, because what most people don't realize is that, for example, the risk of postpartum hemorrhage lasts for months after birth. And, making sure that women have access to that care, providers that understand and can recognize that, is an incredible step forward. I think when we talk about what additional steps can Congress do, I think one, the administration looking at protecting first dollar coverage for access to contraception is a huge part of that. But I think it's also, in going back to my comments earlier, addressing provider training, right? I mean, we know at its core that providers who are not trained and don't have a good understanding and grasp on certain care options and issues are not going to be comfortable talking about that with their patients. I think making sure we find ways in which we can streamline patient access to providers. One example is telehealth, right? Being able to more easily communicate with their providers so that they don't have to require 2 days to take off of work if they have to go back for a secondary visit. And then, of course, making sure that the resources are available to the providers to make sure that they can provide the type of care that they want to their patients.
Yeah, I'm glad you spoke about telehealth, because I was going to ask, before I kicked it off into the audience, is like, how important do you think that the internet connectivity is? And right now, I think we're looking at Congress on whether or not they're going to extend or add, into the budget on internet connectivity program that the president implemented. Now, I think over 20 million people may use internet service. How do you see that impacting, childcare, or people being able to access their medical professionals in that manner?
Where are you going?
No, go ahead.
I mean, you said it plainly, Jasper. You said it in question form, but it will certainly impact, right? So, we've been using, I think, in the nation's conscious, everyone is familiar at this point with social determinants of health, or at least we know the terminology. We've recently been hearing the terminology political determinants of health by Daniel Dawes out of Meharry Medical College. But not too many people often speak about the digital determinants of health, and broadband connectivity has everything, is essentially the essence of digital determinants of health, to the extent that everything that will advance one's life, education, opportunities, all of that is very much associated with being online, with being connected. But to your point about telehealth, especially now following COVID-19, following the pandemic, where if one is bereft of connectivity, then they're going to be bereft of care, right? And certainly of technologies that would advance care. So I think as those of you who are staffers in the audience thinking through in this next Congress, in the 119th Congress, what are some things that you and your bosses can tee up in terms of awareness building around digital determinants of health, in terms of looking at the way that, so I love the point that Linda, you made earlier about working across sectors. So working with FTC, working with all of these other organizations that aren't necessarily health on their head, but they advance or detract people's abilities to make their healthiest choices. Convene them, right, and say, what do we need to do in order to ensure that maternal health rates don't, or can pivot through greater leverage of connectivity.
Yes.
So adding on to all the really wonderful comments my colleagues have made, I just wanted to also point out when we're talking about maternity deserts, of course, those are getting even worse. We're doing a study at George Washington University about the effect of DOBS, actually, and we are seeing OBs leaving states, obviously, not wanting to practice in these states where they cannot provide high quality maternity care. And we're seeing that in these maternity deserts that are only deepening, patients needing to seek out care that are too far away, they can't actually travel to, they don't have the money to get to. There's high-risk cases seeking out community health centers, which community health centers are really the backbone of providing care for our most vulnerable populations. Oftentimes, however, they don't have enough funding to provide the care needed, especially with this influx of patients. So a plug here in terms of increased funding for federally qualified health centers. I also want to talk about, when we're talking about maternity deserts, we're also talking about mental health provider deserts. So going back to what I was saying earlier in my presentation, really important to be looking at those mental health provider deserts, and in particular targeting those for more investment for maternal mental health.
Yeah, I mean, I would just say that, I mean, everything that was mentioned here is spot on, and I mean, any ability to make sure that the patient has an ease of access in contacting and working with their provider, whether it's a community health center or a private care setting, is always going to be constructive when it comes to trying to address patient outcomes. And there's a whole list of other issues that would be part of that discussion as well. But I think increasing that access and the ability to have those conversations, even if it's with their non-traditional provider, being able to communicate what they're experiencing, I think will help us get to the bottom of this.
Cool. So, questions in the audience?
I have a question.
Yes.
Just to go back to HEDIS, the HEDIS measure. The question that I have is, I have really had conversations with healthcare plans in regards to the requirement of HEDIS. And so one of the verbiage in one of the postpartum is that you must have a live birth, right? And so what that means for women, like, well, I had a live birth, but what it means for women that have stillbirth is that they are not in that portion, right? So what that means is, if we are collecting data that says that pregnancy-related complications or death are associated up to 365 days, right? When you have a woman that does not have a live birth, she is not counted in that because she is not deemed as postpartum. So we have a really big problem on the language that healthcare plans are utilizing, because the women that are losing their children, which we know are 2 to 3 times more likely to have a clinical diagnosis, are not being screened because they are not being seen as postpartum. I know this is true because I watched my son die in 2018. They did not check on me. That's why I wrote that book. And that's why I got together with 30 other Black women that had lost their children, that we had not been told that our milk was gonna come in and not have a baby to nurse, right? And so we have to make some changes, and we have to have a standard for the individuals that are putting money in communities that they are neglecting, and they are neglecting women that have to trust the angels to hold their babies until we get there.
For the states whose grades increased, is there a correlation there on being a recipient of the HRSA grant?
I'm sorry, my mind was still going back to answering or responding, but Joy, would you like to respond to that question?
Interestingly, on the screening data for the HEDIS rates, which are imperfect on many fronts, and thank you for raising that one in particular. But a start, we at least have a measure on screening now in the US. We ironically are finding that mandates for maternal depression screening or mental health screening are not leading to higher rates of HEDIS screening rates. We're doing a study as we speak, and a lot of it has to do with reimbursement pathways, which is not surprising. We're also not seeing that the states with HRSA grants or telepsychiatry consult are making a difference yet, which is really fascinating. There's one of our top 8 states that has a telepsychiatry consult program. So we'll have a report out on that soon, and it really is, like I said, to reimbursement strategies and Medicaid agency engagement. We should have more commercial payment strategies that follow suit, but we don't yet.
And just to respond, Ms. Bell, thank you so much for sharing your story. I am so sorry for your loss, and thank you for being here and speaking. So well heard and agreed that the HEDIS measures are far from perfect. And actually, in partnership with the Policy Center for Maternal Mental Health, we submitted a letter this year to the National Quality Assurance Committee, who actually oversees the HEDIS measures, to basically say there needs to be changes to those measures. They're not capturing a whole host of maternal mental health disorders. It only now is depression. And we know that anxiety is often showing up even more than depression, OCD, PTSD, etc. And as you very eloquently pointed out, it's not capturing the full scope of the impact of maternal mental health. So thank you so much.
Hi, thank you everybody today for your presentations, appreciate it. Mia, I want to comment quickly on your conversation about the VBACs. My personal story, I had one child who was like 10 pounds, so he had to be a C-section. My second son was 18 months apart, and they told me I had to have another C-section. I didn't really know to ask more questions at that time. I'm just listening to my provider's advice, and I ended up having 2 more, but my last child was birthed by placenta precreta, and she was 23 weeks premature. She did survive, she's doing okay now, but it was 4 months in the NICU and a long road, and it really all came down to that second C-section that I maybe didn't need to have because my son wasn't even breached. They just told me I had to have that. So I wanted to say thank you for bringing that up. It's an important topic. But my question is, I've just recently been working, invited to work on the New York State Birth Equity Team that's sponsored by the New York State Perinatal Quality Network through Westchester Medical Center, and I've been working with them for like 3 months. But my question is, I'm a teacher, I can talk loud. What are some things I can bring back, like action items to that group that I'm working with right now? Like, what do you suggest, things that I can talk about? What are some priorities? Just maybe an action item or 2, if you can think of any. If not, I can talk to you later.
You look so familiar to me, and I don't know.
Maybe on some of the are you on any of the New York State meetings, perhaps?
I've been to them, but I'm not a member. But I was actually going to say, maybe you can tap into the Fund 2 folk, because they have tremendous partnerships in New York.
I love that. Thank you.
Yep. And we have time for 2 more questions. I think it's a hip over here, and then, oh yeah, you in the back of that. Yeah, I couldn't remember. I saw her hands in the back, but I couldn't see your face because you was. But yes, here on the wall, and then back there, and then just like.
I guess I'll stay on the HEDIS train. So of the 90 measures in HEDIS across 6 domains, NCQA finally recognized that there was probably some potential bias in the absence of social determinants of health drivers and race and ethnicity. Of the 18 drivers that you used to come up with the report card, given that only 8 of the 90 have race and ethnicity stratification in it. How many of those are included within that report card? And then HEDIS is also based on and really focused on those individuals that are enrolled. So how does that report card account for uninsured individuals who are not enrolled? And we'll take a state like California, for example. Pre-ACA was 14% of the women were uninsured. Post-ACA, and even after some of the provisions of Governor Newsom, they're at about 6%. That still accounts for like 2.3 million women in the state of California. And so how does that report card account for that, of those individuals who are not represented?
Excellent question. These are exactly the kind of questions we're hoping people bring out because it's pointing to the fact that that data is not being collected. And so we want people to ask, why is that data not in there? We were able to get more measures this year, as you saw, from 2023 to 2024, but we're wanting even more data to be collected, more measures to be available. So right now, my understanding is there is no collection, standard collection among uninsured individuals, which is so incredibly important. And that states are not required to break down their HEDIS measures by race and ethnicity when it comes to maternal mental health issues. And we know that is absolutely essential. Joy, would you like to add
I was
Uh-huh.
just gonna add that one of the reasons we added the perinatal quality collaborative measure, and niche here is here that monitors the national network, or manages monitor data. So there are other ways we can get at this, even if the HEDIS measure on screening doesn't. We also like to lift up the task force requirement or point measure that states that convene a task force are looking at, generally speaking, looking at the whole population, not just the insured population, Medicaid, commercial, and non-insured. So thank you for bringing that up. And so there are ways that we're teasing it apart, but HEDIS by no means is perfect, so thank you.
Yes, ma'am.
First, I want to say thank you for speaking of the need for more funding for federally qualified organizations, but also for community work. I'm a doula, and I do primarily community-based work, which means 90 to 95% of the patients that I see are either on Medicaid or Medicaid eligible. So my question is for you, Ms. Keys, because we're actively fighting bias in the algorithm and in the intelligence in the hospital. Aside from the 2 studies that you gave us, would there be any other information that we could use that I could take back to equip the doulas that I work with?
What state are you in?
Wisconsin.
You're in Wisconsin. Do you know who your member of Congress is?
Yes.
Okay, are you in touch with them first and foremost? Okay, so that's the #1 step, and I know that you're talking, very hyper local, but is it Gwen Moore by chance?
No, Pocan.
Okay, very good. So getting Pocan's staff on board to just convene the conversation would be important, and to bring some of the, if you're okay with it, either meeting them in district and bringing some of the patients with you to have the conversation, because that's important. The other thing, and I've been spending a lot of time with, on the breast care side, with patients who are undergoing their treatment with respect to breast cancer, and a lot of people they don't know that what they're dealing with is actually artificial intelligence. They don't know that even a little bit of their care is decided by these algorithms. So the first thing, aside from convening with your member, is to really encourage and empower your patients when they're dealing with their providers to ask specific questions. At what point are you basing whatever decision about my care on an AI-powered algorithm? Is it when you're deciding about what kind of medications I need to be on potentially? Is it when you're deciding about what kind of specialty providers I do or do not need? I just need to know. And if there's something because providers aren't necessarily going to say, by the way, for this part of your care, I'm depending on this algorithm, right? And the algorithm, and I didn't go through this whole nerdy situation about like assistive technology versus augmentative technology, but some of it really matters because some of the technologies are just recognizing patterns, and it's up to the provider to say this is what the pattern says. Other tools and technologies are saying this pattern means X, Y, Z, therefore this is the suggested pathway to care. And then we don't actually really see this a lot, but some technologies can operate without the oversight of a provider. We don't see that very often. But what I'm saying is, just start there with your patients.
Thank you so much. And then just a quick follow-up, you mentioned being on that breast care side of it. Are you seeing an uptick in the research and the work that you're doing of maybe mixed diagnoses or missed diseases because of algorithms in the mammogram technology?
For pregnant women?
For pregnant women or just for women, you're like myself, I'm a breast cancer survivor. I was misdiagnosed.
You were
So
misdiagnosed?
I was misdiagnosed because I was young, I was black, I had dense fatty breast tissue, so my cysts were normal. Because of my race.
So this is not a direct answer to your question, but the bigger how many of you know that USPSTF, the United States Preventive Services Task Force, just came out with their newest recommendations around breast screening? Okay, for those of you who don't, look up USPSTF breast screening guidelines. Right now, the guidelines are, so long story short, USPSTF basically says, like sets the standard in terms of when you, through your insurer, should be receiving a mammogram. And it should be covered in your insurance. The guidelines do say that for, unlike in the past, women who are 40 and up should have a screening, and it should be paid for. It does not say anything other than we need more research with respect to women who are under the age of 40, women with dense breast tissue, and especially Black and brown women who are presenting with advanced stages a lot sooner than average. So I'm just going to leave you to your own imagination about what has to happen. Talk to the members of Congress, talk to the members of Congress, talk to the members of Congress, because they are the only ones that can really, not the only ones, but they and the staff who can be in touch with USPSTF to say, hey, listen, the next time these guidelines come out, we need additional research with respect to dense breast tissue. Also be in touch with the Dense Breast Foundation, because they also have power and access to moving those guidelines.
Thank you.
Yeah.
Thank you. Yeah, one last question, and then we're free, want to make sure that you guys can grab some breakfast before you get out on this one. Yes.
Actually, this is just a call, I'm sorry.
Yeah, no, you're fine.
You're doing, all right. So, Fund to Foundation, we have 7 task groups, and one of the task groups is technology and Black maternal health. And I just want to put the call out, contact us if you're interested in it. What I've discovered is when you're trying to do this work in a holistic manner, the usual suspects are not the low-hanging fruit. Right. They are over inundated and oftentimes out of touch. They don't even include gentrification in some of their data. But anyway, that's another story. But AI, MIT has an AI program this summer where for 2 weeks, they're taking kids from HBCUs and having them literally go through an MIT certified course. And they're teaching it in fields, the health field, the financial field. In other words, we have to be present there. See, it's not just, I believe in putting your fist up, but at the same time, sometimes you have to sidle into things. So if anybody's involved in getting involved with that, interested in getting involved, let me know, because we sponsored 10 kids to go. It's only $5,000 a kid for 2 weeks. And just think about the impact they're going to make apps. Yeah. There's also a thing called a federal there's a transfer, what is it, NSA and NASA, they actually have apps that they will pay you to put out there. There's so much stuff that we don't tap because we keep beating that same door down. Mm-hmm. So contact us. We actually have a task force. If you're interested in being on it, Mia's on it.
We have a meeting today at 12.
Hey, they meet today. We work with them. Let me tell you, don't come in there trying to talk. It's all about but seriously, their AI is an answer, and there are hackathons all over the place. So I will suggest that we talk about having a booth at Afrotech this year.
Nice. That's a great idea.
Okay? Afrotech, that's where the kids are, right? Yep. And that's where, hey, how many, 20,000 kids? Also said they never saw so many behaved Black people in their lives. So it's gonna be in Houston, so let's do that.
Okay. All right, well, thank you all. We've heard a lot of suggestions today. We've heard from our members of Congress, and we'd like to thank them again and thank the staff for all of your hard work and helping us to secure this room. This has been a very busy week in DC, very expensive week in DC. But we made it through, and we've heard a lot of collaborative suggestions. And so I will encourage each of you to meet someone here today that you did not know before you arrived here today, and let's see what we can do together to improve the lives of mothers and babies across the world. So thank you again.